Thank you for joining us today. My name is Emily Sego, Clinical Healthcare Executive at Nihon, Kohden, America. I'd like to welcome you to our webinar, Better Data, Better Decisions, Train of 4 Monitoring that Fits Your Workflow. We are excited to have healthcare professionals from across the globe joining us to discuss an important topic in perioperative patient care, quantitative neuromuscular monitoring. Before we begin, a few housekeeping items. This webinar is being recorded and may be made available after the event. We will reserve time at the end of the session for audience questions. We encourage you to submit questions throughout the presentation using the Q&A feature. Please note any questions you submit could be included in the recording. If we are unable to address all questions live, we will follow up as appropriate. Today's discussion will focus on how quantitative neuromuscular monitoring can support clinical decision-making and contribute to improved patient safety and outcomes. We'll also explore how the NMT Pod can support consistency, accuracy, and clinician confidence, along with practical guidance for setup and use. Our first presenter is Dr. Tsai, who will provide valuable clinical insights into neuromuscular monitoring. Dr. Tsai earned his degree in chemical and biological engineering from Princeton University and received his medical degree from the Perelman School of Medicine at the University of Pennsylvania. He recently completed his anesthesiology residency and will be joining Beth Israel Deaconess Medical Center as an attending anesthesiologist while also serving as an instructor at Harvard Medical School. We are honored to have Dr. Tsai share his experience and perspectives with us today. Our second presenter is George Kirschling, RN, clinical consultant with Nihon Kohden, America. George brings over 20 plus years of clinical and patient monitoring experience. George has a passion for helping healthcare organizations leverage technology and share evidence-based practices to enhance patient care. Thank you, George and Dr. Tsai, for your time today. With introductions complete, let's begin today's presentation. Dr. Tsai, the floor is yours.
Thank you for that introduction, Emily. Good afternoon. My name is Tsai, and I'm an anesthesiologist. Thank you for attending today's presentation on Better Data, Better Decisions, Train of 4 Monitoring that Fits Your Workflow. In my talk today, I will address the following learning objectives. First, how akinesia is a key component of anesthesia. Second, how quantitative neuromuscular monitoring improves patient safety and outcomes. Third, how the Nihon Kohden NMT neuromuscular transmission pod makes all of that happen, how I use it in my practice, and how you can use it in yours. To address these topics, we first need to answer the question, what are the goals of anesthesia? And it's the 3 A's, akinesia, amnesia, and analgesia. We're going to focus on akinesia today and how it relates to all stages of our anesthetic, induction, maintenance, and emergence. On induction, how do we know when the patient is adequately paralyzed and the vocal cords are open for a successful first pass intubation? For maintenance, anesthesia makes it possible for surgery to do what they need to do. Surgeons don't appreciate it when the patient moves while they're operating. And so what that means for us is that just as we care about anesthetic depth, that the patient is appropriately amnestic, we also need to care about depth of paralysis. How paralyzed is the patient, and when is it time to redose paralytic? Finally, after surgery is done, not only do we need to wake the patient up, we need to reverse the paralysis and ensure that they don't have residual paralytic on board. Incomplete reversal of paralytic agents is a patient safety issue because it can lead to complications such as airway obstruction, aspiration, prolonged stay in the recovery area, and recatheterization. So this raises the question, how do you know when the patient is sufficiently reversed that you're unlikely to encounter these issues? So to that end, you can look for qualitative indicators to see if you are where you need to be for akinesia. On induction, mass ventilation becomes easier. During maintenance, surgery won't be complaining, and the patient will be synchronous with the ventilator. And on emergence, maybe you're looking for clinical signs to demonstrate recovery, such as appropriate tidal volumes, head lift, and hand grip. During these 3 phases, you may be using Train of 4, where you send 4 small electrical pulses to a nerve such as the ulnar nerve or facial nerve, and you feel for the strength of muscle movement. But frankly, qualitative assessments of akinesia just aren't good enough for modern practice, not with the technologies that we have today. And this is especially true for emergence because a patient can lift their head, have a great grip, have 4 strong twitches, and still not be sufficiently reversed from paralysis, which can then result in post-operative anesthetic complications. That's why the American Society of Anesthesiologists in their 2025 practice guidelines recommend using a quantitative measurement, a train of 4 ratio greater than 0.9 prior to extubation. Now, what is a train of 4 ratio? Well, it's sending those 4 electrical pulses that I mentioned earlier. If you have 3 twitches, you have a train of 4 count of 3. If you're more recovered from paralysis, you'll have 4 twitches. And at that point, we start looking at the ratio of the 4th twitch to the 1st twitch. As seen in the image, the 4th twitch has a strength 50% of that of the 1st twitch. We call that a train of 4 ratio of 0.5. Now, why did the ASA pick 0.9 as a standard? Admittedly, a 90% on a report card looks a lot better than a 70, but why 90? And the goal, in fact, did used to be 0.7 because a patient's vital capacity and inspiratory force are nearly normal at this ratio. But over the past few decades, this target has adjusted upwards because what has been found is that at a ratio less than 0.9, there's still too much residual neuromuscular blockade on board. You run an increased risk of airway obstruction, impaired airway protective reflexes, and an increased risk of aspiration. In fact, a study from 1997 subjected awake volunteers to an infusion of paralytic and tested them at different train of 4 ratios to see how they felt and what physical movements they could do. And what the authors conclude in their paper is that a train of 4 ratio of 0.7 does not signify a satisfactory return of neuromuscular function. In fact, while their volunteers could maintain their airway, they were not, quote, street ready. They had diplopia, an inability to sit up, severe facial weakness, and overall weakness and tiredness. To recap, so far we've discussed akinesia and how it applies to induction, maintenance, and emergence. I've also emphasized the need to fully reverse paralysis at the end of a procedure, which requires measuring it by a standard that is not qualitative but rather quantitative, with the goal being a train of 4 ratio greater than 0.9. I now transition to talking about the NMT Pod. What is it, and how do I use it from induction to emergence? First, the NMT Pod is an EMG monitor. EMG stands for electromyography. Breaking that word down to its components, we have electro for electric, myo for muscle, and graphy for measurement. So this tool measures the electrical activity of muscles. On induction, I place my ASA standard monitors on the patient: pulse ox, EKG stickers, blood pressure cuff. I also place the NMT electrode on the patient's wrist, on the medial side where the ulnar nerve runs. I reinforce that sticker with a piece of tape because over the duration of a long case, the weight of the connector and cable can cause the electrode to lose contact, which can impact its function. I pre-oxygenate, push my medications, and then I wait. During this wait, I then have my train of 4 running. I see the twitches go away from 4 to 3 to 2 to 1, and it's around here that I know that sufficient time has elapsed for my paralytic to work, and then I can proceed to intubate. During maintenance, one of the nice things about having this monitor is that I don't have to physically check for twitches myself every 15 minutes. There's no more ducking under the drapes or trying to feel where a thumb is, or asking myself, this twitch that I have, is it stronger or is it less strong compared to the one that I just had before? This monitor just runs, and it runs on its own. In addition, those situations where the arms are tucked tight because a robot is docked and I can't even get past the apparatus to check on my IV, much less feel for a thumb twitching, well, this monitor still works because its data comes not from needing the muscle to have space to actually move, but rather the electrical activity and the muscle itself. During maintenance of anesthesia, I use the data that this monitor produces to guide my paralytic dosing. For your average patient, there's a general sense that you need to redose every 20 to 30 minutes, with a maintenance dose that is less than what you use for induction. But there's wide variability, especially with older patients or patients with impaired hepatic or renal function. You just don't need to give as much. And the point that I'm trying to emphasize here is that you should give what you need to give, not more and not less. You should be judicious. And so for me, after getting a sense of how quickly my patient is recovering twitches from my induction dose of paralytic, I will target a post-tetanic count or PTC of around 5. When a train of 4 is 0, you can run a post-tetanic count to see just how deep is your neuromuscular blockade. The number of single twitches that result is known as the PTC, or post-tetanic count, when you have the monitor give a tetanic stimulus and then fire single twitches. For cases where no patient movement can be tolerated, such as if the patient is in pins or a robot is docked, I'll err on the lower side of 5. But if I don't need that strict level of akinesia, or if the surgeons are starting to close, I'll let the PTC rise above 5. My reference point that I keep in mind is that a post-tetanic count of 10 is usually equal to about a train of 4 of 1. But as seen in the image on the right from Bonsu et al., there is variability within our patient population. So far, I've been advocating for the judicious titration of paralytic in a data-driven manner. But that raises the question, in our practice of anesthesia today, are we actually not being judicious? And the answer to that question is yes. From this paper by Wachtendorf et al. Published in March 2026 in Anesthesiology, what they found is that at their institution, after Sugammadex was introduced in 2016, over time, not only was there an increase in Sugammadex utilization, there was also an increase in rocuronium dosing. The Sugammadex is indicated by the maroon line, the rocuronium by the gray dots. Now, part of this trend perhaps we can explain as with the introduction of Sugammadex, a medication that encapsulates rocuronium or vecuronium and is a very effective antidote for these paralytics, we can achieve greater levels of akinesia. And if that makes life easier for us and our surgical colleagues, isn't that a good thing? And unlike prior medications such as neostigmine and glycopyrrolate, which have a maximum dose because of a ceiling effect, you can give as much Sugammadex as you want to reverse however much paralytic is on board. But I'd like to caution against that kind of thinking and against this heavy-handed practice by extending an analogy to opiates. In this current practice climate in America, we're very judicious about opiates. At times, we endeavor to run opiate-free anesthesia because we're concerned about respiratory depression in the postoperative setting, as well as the addictive potential of opiates. And the point that I'm making here is this. In the medications that we administer during the course of anesthesia, opiates or otherwise, we're judicious about what we choose to administer and the amount that we choose to give. As such, we should be judicious on paralytics as well, even with the presence of a reversible agent such as Sugammadex. This is because when you dose paralytics more heavily, unless you are vigilant about exactly how much Sugammadex you need to administer, your safety margin decreases. Sugammadex, per the manufacturer Merck, is dosed at 2 milligrams per kilogram if you have a train to 4 ratio greater than 2, but at 4 milligrams per kilogram if your train to 4 ratio is at 0. Now imagine your patient is 110 kilograms. They have a train to 4 of 2. Technically, they should be getting 220 milligrams of Sugammadex. But because Sugammadex comes in vials at 200 milligrams, this means that you need not 1, but 2 vials of medication. And are you, or whomever is taking care of the patient, really going to open up a second vial? Maybe your answer is yes, but a good number of people won't, whether it's out of laziness or concern over medication cost or medication waste because it's just 20 more milligrams. So now we run into the issue that because of Sugammadex and its existence, we have a false sense of security that after we give it, we won't have residual neuromuscular blockade. We are subsequently less judicious about our paralytic dosing, and we're probably not very careful about our Sugammadex dosing. And that same paper from Wachtendorf et al. Found that there is a dose-dependent risk with rocuronium for post-operative respiratory complications. The more paralytic you give, the more likely you are to run into trouble. And so what's the solution to this dilemma? As discussed earlier, the solution and the expectation of practice is to have a standard of train to 4 ratio being greater than 0.9. So in my practice, as a case starts to wind down, as I begin my emergence, I don't redose my paralytic. If the surgeon complains that the patient's moving too much, I utilize small doses of propofol instead. I look to my train to 4 monitor to see where I'm at and how fast my patient is recovering. I then administer Sugammadex and continue to monitor my train to 4. If my train to 4 climbs rapidly and reaches the threshold of 0.9, I know I don't need to redose. But if my recovery slows down and levels off at, say, 0.6, this indicates to me that there's still free-floating paralytic working at the neuromuscular junction. I need to give more Sugammadex. Now, I've emphasized the importance of judiciously dosing paralytic and sufficiently reversing it to prevent postoperative complications. I'd like to briefly discuss the postoperative complication of recurribrization. If you have a patient in the postoperative area who's desatting, guppy breathing, looking weak, have this on your differential. Breaking the word down, the prefix re means again, curare means paralytic, and zation means process. So this is the process of becoming paralyzed again. Suffice to say, this is not something a patient would like to experience from anesthesia. The exact mechanism of action of this phenomenon remains incompletely defined, but the current hypothesis is that the paralytic works in the peripheral neuromuscular junction. Sigamodex, when introduced to the patient, enters the central compartment, which creates a driving force for paralytic to exit the periphery and enter that compartment where it is bound. But somehow, over a period of time, paralytic re-enters the periphery and the patient experiences paralysis again. There have been case reports of this phenomenon occurring even with patients having a train-to-4 ratio greater than 0.9. In the case reports, abstracts, and poster presentations that I've looked at regarding this phenomenon, there's always some kind of red flag that I notice. The patient had hepatic or renal impairment. There was a late and large dose of paralytic administered right before emergence. Instead of using EMG technology, the patient had AMG technology or accelerometry, which is a different sort of train-of-4 monitoring. Or quite frankly, that too much paralytic was administered intraoperatively to achieve a level of akinesia that simply was not needed. And its corollary, that not enough reversal agent was administered. A rule of thumb that I keep in mind for myself is that if you had a test tube with 200 milligrams of Sigamodex, and the question being how much rocuronium could this 200 milligrams bind to, the answer is that it's about 50 milligrams of rocuronium. Keep in mind, of course, the human body is not a test tube. There's compartments, gradients, cell junctions. It takes time for Sigamodex to bind to paralytic. But I know if I only administered 50 milligrams of rocuronium on induction, the case has proceeded for 30 minutes to 2 hours or even more. 200 milligrams is probably more than enough for what I need to reverse the patient. Again, I believe that recuriorization is a preventable post-operative complication, and through the utilization of quantitative neuromuscular monitoring, you can ensure that you are at the depth of akinesia that you intend to be at, and that you don't redose paralytic needlessly. In conclusion, the takeaways from this presentation are as follows. First, that quantitative neuromuscular monitoring is superior to qualitative assessments. Second, that quantitative neuromuscular monitoring should be a part of your practice to prevent post-operative complications in your patients. Third, that you should judiciously dose paralytic. And finally, I hope you come away with the understanding of how you can use quantitative monitoring to guide your decision-making in all phases of anesthesia: induction, maintenance, and emergence. Thank you for your time and attention.
Thank you, Dr. Tsai, for those insights. Now let's hear from George as he provides a demonstration on quantitative neuromuscular monitoring in practice.
Thanks, Emily. Good afternoon and welcome to Nihon Kohden's Customer Experience Center. Today we're going to talk about the Nihon Kohden AF201P NMT Pod, our automatic quantitative train of 4 device. There are 2 components to the device itself: the pulse generator you see here, and also the patient-worn sensor. Let's start by we'll begin by talking about the pulse generator. The pulse generator itself is a component of the Nihon Kohden Patient Monitoring Center. It comes with a convenient pole clamp that allows for easy positioning in a number of places, typically a drape pole or something convenient like that. It connects to your Nihon Kohden monitor via a Nihon Kohden smart cable and the universal multi-ports. These are comparable to a USB-style connector in that it allows for the connection of a multitude of patient parameters via a single yellow port. So any device, invasive blood pressure, thermodilution cardiac output, BizX monitoring, and of course the train of 4 pod can be plugged into any available port on the Nihon Kohden monitor. And when I do, it will automatically sign on in a pre-assigned spot on the patient monitor. This will serve as our key to access the vital sign. The information that's displayed there includes your twitch bars, as well as your current train of 4 ratio, or when appropriate, the train of 4 count. We'll get back to this device in a moment. First, let's talk about placement on the patient's hand. This is our EMG sensor, individually packaged. It opens easily and the sensor can be removed. The sensor itself is comprised of 3 components. We'll start here at the bottom with the stimulation electrode. This is placed over the ulnar nerve. You'll notice there are 2 landmarks or identifiers on here. They include a neutral grounding electrode and also the Nihon Kohden patient monitoring logo. The second electrode is the active electrode. This electrode is placed over the monitor that the muscle that you're monitoring. so that it can detect the electrical activity within that muscle. And then finally, the reference electrode. The reference electrode is provided, is attached to the corresponding digit of the muscle that we're using. We're going to be placing this on the muscles of the hand. It helps to ensure accuracy of the readings. All right, now this sensor will separate into 3 convenient sections so that it makes it easier to apply and prevents things from getting tangled. I'll show you a demonstration here and then we'll go ahead and apply. As I mentioned, there are 3 positions that we can use on the hand for the sensor. The first is the interosseous muscle you see here. Okay, we're placing the, we have placed the stimulation electrodes over the ulnar nerve, the active electrode over the interosseous muscle, and the reference electrode to the side of the corresponding digit, in this case, the index finger. We taped it to the side and have voided the meaty part of the finger to help isolate it electronically. A second position that we can use that is very popular, thank you, go ahead and remove this real quickly, is the adductus pollicis. This is a popular sensor, especially since it's mentioned so frequently in the literature. Again, we've applied the sensor over the ulnar nerve. We'll demonstrate that application in just a moment. We have applied the active electrode over the belly of the muscle, and the reference electrode, again, on the side of the corresponding digit, in this case, the thumb. Okay? Now, when it comes time to place this, we're going to turn back to, again, these indicators that are on the transmitter and a landmark on our patient, which is going to be the interosseous, the pisiform bone. I apologize. We'll go ahead and open that up. Now, you can be placed on either extremity. In this case, because we're using the left extremity, we're going to align the Nihon Kohden logo with the pisiform bone. If it was the other arm, we would use the neutral electrode as our reference point. I'm going to line that up first with the bone, and then kind of extending the pigtail, I'm going to draw a straight line to our patient's elbow. Okay? This placement gets it over the ulnar nerve initially, but also keeps it over the nerve as we reposition and secure the arm. Now, this is the position that Dr. Tsai mentioned, where we're just going to follow that path of the ulnar nerve, the primary path, through the adductus minimi here, and then using the pinky as our reference digit. So again, placing the active electrode over the belly of the muscle and securing that in place, and then our reference electrode. The last thing we're going to do is we're going to attach the cable and secure it into place. Patient cable attaches conveniently to the end of the electrode sensor. We'll cushion that with a 2x2 here and put a piece of tape over it to help secure it in place. That holds the cable, protects the sensors, and also the patient's arm. Let's switch back to the monitor then, please. All right, so when we look at the monitor here, we're going to go ahead and enter the parameter by touching our train of 4 key. When I do, the menu opens for train of 4. Now, this is a very familiar looking menu if you know the Nihon Kohden patient monitoring system. At the top, we have a list of our available parameters that we are monitoring. And we can see that currently we're in the train of 4 parameter, and within that parameter, the readings menu. We have a couple of different menus that we can go to. For instance, there's stimulation and sensitivity. This allows for the stimulation current, pulse width, and the sensitivity of the device to be adjusted manually should it be required. We also have a sound and display key where we can control the noises or alarms that come from the device, as well as how we want it to look. For instance, do we want to see an EMG waveform, or do we want to see a twitch bar? I'll go ahead and select twitch bar because that's familiar to all of us, I think. And then lastly, the last key up here says program mode. This is an important mode because this is going to dictate our predefined settings for how we want the train of 4 to progress. This These settings are programmed according to your departmental standards, but can always be adjusted either on the fly or prior to the case as needed. You'll notice that it is broken into 3 different parts. We have our induction, our active or deep anesthesia phase, and our recovery phase. We also have 2 indicators up here that I'll explain in just a moment. So if we look at our current settings here, we have during induction mode, our train of 4 monitor is set to measure every 5 minutes, okay? Once the train of 4 reaches 1, it will then enter the deep phase of monitoring. Here, we've programmed it to record the train of 4 every 10 minutes and the PTC every 10 minutes as well. And again, this could be 15, it could be 5, whatever number you desire, we will program into that. As the deep stage of anesthesia progresses and we enter the recovery phase, this will be indicated in this instance of a train of 4 a train of 4 of 4. We can touch that and adjust that as well as required. It will then switch to a recovery phase. Again, in this instance, programmed for every 5 minutes. Okay. Now that we've explained the program mode, let's go back to the readings mode because now we're ready to begin monitoring. If we describe the screen real quick, at the bottom right-hand corner, we have keys to access our vital sign trending so we can see our patient's progress over time. Over here is the calibration area. No numbers there yet because we haven't yet initiated monitoring. In this area, we'll display our train of 4, but first it asks, has the paralytic drug been administered or not administered? So in other words, if we have pushed a sedative, we can then turn around and choose drug not administered. The device will then calibrate itself to the patient. In other words, adjust that amperage and other settings to the unique characteristics of our patient here. If the drug has been administered, we'll touch this key here. The end result is the same though. The device will automatically enter the program mode and begin your measurements for you. In this case, let's say I've pushed my sedative. I'm now going to pause and turn around and say drug has not been administered. This is going to automatically tell the monitor to perform a calibration. And when it's complete, we'll see those numbers appear on the screen here. So again, it has been customized for our patient. It has immediately followed up that calibration with a train of 4 reading. Okay, here are our 4 twitch bars. Here is our train of 4 ratio of 102. We are currently in the program mode, so it has been started. And if we look at the bottom here, we can see that the induction phase is highlighted to, indicate that that is the mode that we are in currently. As the case progresses, it will automatically progress here. And of course, again, you can touch those, you can go to program settings and adjust those as you need to throughout the case, or you can do an individual reading, like a single train of 4, a single PTC. You can also measure a single twitch or stop the program mode altogether. For instance, at the end of the case. So we'll go ahead and simulate that right now. Program stop. Very good. All right. Again, all this information is being saved within the monitor where we can review it in our trend formats, but perhaps even more importantly is that it is able to communicate directly with the EMR as well. Thank you.
Thank you both for the excellent presentation today. We will now move into our Q&A session. As a reminder, if you have questions, please submit them through the Q&A panel. And I do not see any Q&As at this moment. I will conclude the webinar here in just a second, and I'll see if anybody has any other questions before we stop. So just thank you so much, Dr. Tsai and George, for sharing your expertise today and practical insights on quantitative neuromuscular monitoring and the role of train of 4 monitoring in supporting better clinical decisions. And thank you to all of you for joining us as we explore how quantitative neuromuscular monitoring can help clinicians deliver safer, more informed care for every patient. We appreciate your time and commitment to advancing patient safety and clinical excellence. If you'd like additional information about Nihon Kohden's NMT Pod, please reach out to your Nihon Kohden representative or visit our website at us.nihonkohden.com. And at this time, I do not see any other questions in the Q&A, so we will conclude the webinar. Have a wonderful evening.